Recording in progress.
Okay. Hello, everyone. My name is Miss Ines Al-Hatan. We're talking today about the cerebrovascular accident, and as we call stroke. Cerebrovascular accident, it's a medical term for a stroke and also called a brain attack. It's the sudden death of some brain cell due to the lack of oxygen. So it means when the oxygen is not conducted to the brain, it can lead to death. So it occurs when the blood flow to a part of your brain is stopped either by blockage, and as we call it ischemic, such as a floating clot or a stationary clot, or a rupture of a blood vessel or compression, and we call it hemorrhage. And as you can see here, the symptoms of a stroke. Symptoms of a stroke depends on the area of the brain affected. As if we have like the damage in the right side, it will affect the left side of the body or the opposite side of the body. Stroke symptoms signify a medical emergency, and the symptoms of a stroke depend on the area of the brain affected. As we see here in the picture, this patient, he has a focal neurologic signs. We can see a paralysis and sensory loss, a language disorder, and reflex changes. Also the same with the TIA, which is a transient ischemic attack. So here he has an hemiparesis and hemiplegia, hyperthermia, emotional liability, visual changes, vomiting, perceptual defects, hypertension, and apraxia. And let's follow. So the definition of stroke severity. We have the mild stroke, and the patient will be alert with any or combination of symptoms such as a mild motor weakness of one side of the body, sensory deficit, slurred speech, vertigo with incoordination, visual field defects alone. And actually, here we are using the NIHSS, which is a National Institute for Health Stroke Scale. And we will talk about that later in detail. The moderate stroke, the patient is awake with significant motor or sensory or visual deficit, or disoriented, drowsy, or light stupor with purposeful response to painful and stimuli. So the patient, he already responded to the pain and stimuli. In the severe stroke, here we are talking about the patient, he's comatose, or he is in a coma, so he's not responding to the stimuli or to the pain. Stage of CVA. It started like a TIA or the transient ischemic attack, and which is a stroke, but it's resolved in the first 24 hours. So the transient ischemic attack, sudden and short-lived attack. The other type is a reversible ischemic neurological deficit. It's similar to TIA, but the symptoms can last up to 1 week. Stroke in evolution, it's a gradual worsening of symptoms of brain ischemia. And the last one is a completed stroke. Symptoms of a stroke is stable over a period and rehab can begin. And here we can see the classification of a stroke. There is a primary, ischemic, and hemorrhagic. As we can see, ischemic is 80% of a stroke, and hemorrhagic it's 20% of a stroke. And here also we can see with a CT scan, transient ischemic attack. TIA was traditionally defined as a neurological deficit, the symptoms of which are defined cured completely within 24 hours. The current definition of TIA is the acute onset neurological dysfunction due to focal brain ischemia, which completely resolved within 60 minutes. And there is no evidence of cerebral ischemia. And here the first few hours. Time is brain. See the penumbra. The penumbra, this is the zone, as we can see in the picture, reversible ischemia around core of irreversible infarction. Salvageable in first few hours after ischemic stroke onset. And it can be damaged by the hypoperfusion or hyperglycemia, fever, or even seizure. What are the risk factors for stroke? The risk factors, there is a modifiable risk and non-modifiable. The modifiable, like the hypertension, carotid diseases, are atrial fibrillation, diabetes, weight, high cholesterol, lack of exercise, drug abuse, coagulopathy. And the non-modifiable risks like the age, if the patient is above 55, race, if it's an African American, 69% greater chance in men and 61% of stroke death occur in women. And also the previous stroke or TIA, family history or stroke. Sign and symptoms. In embolies, usually it occurs without warning. The clients often with history of cardiovascular disease. So for sure, we have to ask first, if we got a case of a stroke, we have to ask like if we have a previous symptoms or signs for cardiovascular disease or a previous stroke before. In thrombosis, dizzy spells or sudden memory loss, no pain, and the client may ignore symptoms. In cerebral hemorrhage, may have warning like dizziness and ringing in the ears and violent headache with nausea and vomiting. Sudden onset CVA, it's usually most severe, loss of consciousness, face becomes red, breathing is noisy and strained, pulse is slow but full and bounding, elevated blood pressure, and maybe in a deep coma. Time is critical. The longer the time period that the person remains unresponsive, the less likely it is that the person will recover. The first few days after onset is critical, and the responsive person may show signs of memory loss or incontinence behavior, may be easily fatigued, lose bowel and bladder control, or have poor balance. Okay, immediate diagnostic studies. Actually, here we have to do all the investigations for the patient suspected with a stroke. Why? Because we do need to know if the patient, if he has a diabetes or if he has a previous stroke or cardiac diseases, all of these. But the most important here, I have to talk about the RTPA or the MRI. We have to do it before. It's described to know the result of this test before giving the RTPA or thrombotic therapy. Shouldn't be delayed while awaiting the results unless there is clinical suspicion of a bleeding abnormality or the patient has received heparin or anticoagulant is not known. So we have to keep focus on that. Stroke awareness. Here we can do a test just to know that if the patient has a stroke. We use the word fast. It's a facial asymmetry, arm drift, slurred speech on time. For the facial asymmetry, have the person smile or show his or her teeth. If one side doesn't move as well as the other, or it seems to droop, that could be sign of a stroke. Arm drift, have the person close his or her eyes and hold his or her arms straight out in front for about 10 seconds. Look for weakness or drift. Slurred speech, have the person say, you can teach an old dog new trick, or some other simple familiar saying. If the person slurs the words, get some words wrong, or is unable to speak. If any of the above three is present, then patients are advised to seek immediate hospital consultation. And here we can see the fast, face, arms, speech, on time. Stroke scale, actually, as we know, we are using glaucoma scale for the patient with a stroke. And actually here we are looking to 3 points, the eye opening, the verbal response, and the motor response. And we are talking about that later in the second part of the stroke with the management for stroke patients in the subacute and chronic cases. And here also it's another scale we can use, a modified Rankin scale, like no symptoms at all. We're using 0, 1, no significant disability despite symptoms, and he is able to carry out all usual duties and activities. And 2, it means a slight disability, unable to carry out all previous activities, but able to look after own affairs without assistance. And 3, it means moderate disability requiring some help, but able to walk without assistance. 4, moderately severe disability, unable to walk without assistance and unable to attend to own bodily needs without assistance. 5, severe disability, incontinent and requiring constant nursing care and attention. And 6 is death. The investigations, as we said, we have to do all the investigations that we could do like the CT, MRI, full blood count, serum electrolytes, renal function, blood sugar to know if the patient is diabetes, full blood count to detect polycythemia or endocarditis, clotting studies for hypercoagulable states, ECG, arrhythmias, and myocardial infarction. Yeah. Here we can talk about the medical management. For the management, is taken supportive management. We have to look to the airway, temperature, blood pressure, blood glucose, and cardiac assessment, thrombolysis, intravenous, intra-arterial, and antiplatelet drugs and anticoagulant drugs, hemodilution and vasodilators, and include hypertension, neuroprotective agents. Stroke management, growth. Symptoms and signs suggestive of a stroke. The symptoms and signs persist more than 1 hour. The acute care, urgent clinical evaluation. We are doing the ECG, the blood test, urgent brain CT, and also MRI. For the ischemic stroke, there is an CT and a specific stroke therapy. Like we have to look to the thrombotic therapy if no contraindication and antiplatelet therapy. If it's hemorrhagic, we are doing the ICH and CAH, and the brain CT showed hemorrhage. Neurosurgical for the evaluation and treatment. Acute stroke care, stroke unit if available, airway, breathing, circulation, hydration, blood pressure monitoring, neurological state monitoring, anticipate and treat complication, begin rehabilitation. Neuro rehab, multidisciplinary team approach. Proper positioning, and actually we are doing that with a physiotherapy and physician and the nurses too. All the multidisciplinary team, they can start with the proper positioning, early mobilization, physiotherapy, occupational therapy for treating the spasticity and treating depression, further investigations like established stroke, subtype and underlying cause, cardio and cerebrovascular risk, and the assessment. Education for the patient and caregiver. And the secondary prevention, antiplatelet therapy, treat risk factors, and treat the specific underlying cause. Here we have to look to the factors and the recommendation. For the hypertension, for example, we have to know that lifestyle changes if blood pressure between 130, 140 systolic and 80 to 90 diastolic. The target blood pressure for diabetic, for sure it differs than the normal one. So it has to be less than 130 systolic and less than 80 for diastolic. Hypertension should be treated in a very early and the age above 70s to reduce the risk factor or the risk of a stroke. Also, we have to control if he's diabetic and smoking, cessation of smoking. For the medication, you can take an aspirin therapy, milligram, post-menopause hormone replacement therapy. And for the alcohol, you have to avoid heavy alcohol consumption. General management of acute ischemic stroke, the airway and breathing, ensure that it's a clear airway and adequate oxygenation. Elective intubation may help some patients with severely increased ICP. Mobilize early to prevent a complication, but I'd prefer if we are doing the mobilization in the bed and prevent to move out of the bed for the first 24 hours. Blood pressure, don't treat hypertension if it's less than 220 systolic or less than 120 diastolic. Mild hypertension is desirable at 160, 180 systolic and 90 to 100 diastolic. And also blood pressure reduction shouldn't be drastic. Also the blood glucose treating the hyperglycemia and they treat by insulin and they treat the hypoglycemia with glucose infusion. Also the nutrition, perform a water swallow test and insert a nasogastric tube if the patient fails to swallow test. The infection, we have to search for infection if fever appears and they treat with appropriate antibiotics early. Fever, we have to use the antibiotic to control elevated temperature. And also there is the intracranial pressure for hyperventilate to lower intracranial pressure. The treatment with RTPA in selected patient presenting within 3 hours with 10% given as a bolus followed by infusion over 1 hour. Aspirin, we have to start aspirin within 48 hours of a stroke onset, and use of aspirin within 24 hours for RTPA isn't recommended. So we have to make sure if he already took the IV RTP or not. The anticoagulants is the use of heparin, low molecular weight heparin, or isn't routinely recommended as it doesn't reduce the mortality in patients with acute ischemic stroke. Neuroprotective agents, a large number of clinical trials testing a variety of neuroprotective agents have been completed. These trials have thus far produced negative results. To date, no agent with neuroprotective effects, so actually it's not recommended. Okay. After that, we'll talk about the surgical treatment, surgical removal of hemorrhage with cerebral decompression for patients with cerebral hemorrhage or with brainstem compression, standard craniotomy for patients with prevention and management of complication. Management of complication improves both short-term and long-term prognosis. Avoiding illicit drugs, low fat, high fiber, quiet smoking and alcohol intake, exercise, controlling diabetes, and maintain healthy weight. Complication of stroke can be divided into general medical and neurological complications. They can also be divided into acute if it is less than 7 days, or subacute if it's more than 7 days, based on time of occurrence. As we said, we have to time is at premium, young stroke patients, early identification, good and very satisfying results, drug available, neuroimaging available. We have to make sure of all of these if we have a stroke patient. And as to remember, time is brain. Thank you.